Great. Welcome everybody to yet another edition of the New England Sleep Seminar Series. My name is Andrzej Zinchuk. I'm an assistant professor here at Yale University and a sleep doc and researcher. And this is our sixth official year of running this conference, and really excited about all the informative sessions that we've had from people around the country. And this conference includes specifically folks from Yale School of Medicine, folks from Harvard, Beth Israel, Leahy, Mass General, Tufts, Boston, and now with great pleasure and honor, we have the Brown School of Medicine joining us as well. And so I am excited for this afternoon's talk, and I know Dr. Vesna Buntak, our former sleep fellow, who is now faculty at Brown, will introduce Dr. Katie Sharkey, who is our esteemed speaker for this afternoon. And what I would just say is that at the beginning of the session, you should be muted. If you wanted to get credit for CME credit for attending today's discussion, please check the chat. There'll be a code that will allow you to do so. If you haven't registered with the LCME, you would have to do that ahead of time. And then if you have questions throughout this session, please add them to the chat, and Vesna and I will make sure that we either unmute you or ask the questions for you. And without any further chatting on my end, I'm gonna let Dr. Buntak say hello.
Good afternoon, everyone. It is an absolute pleasure to introduce Dr. Catherine Sharkey, a distinguished physician, researcher, and educator in sleep medicine. Dr. Sharkey's journey began at Rush University, where she earned both her MD and PhD, with her doctoral research focusing on the role of melatonin in circadian rhythm shifts and sleep and night shift workers. She then completed a dual residency in psychiatry and internal medicine before joining Brown University. Here, she serves as an associate professor of medicine and psychiatry and associate dean for gender equity. A leading expert in perinatal sleep research, Dr. Sharkey has made significant contributions to understanding the intersection of sleep, circadian rhythms, and mental health. She has authored over 100 publications and has been invited to speak both nationally and internationally. Her research funded by, funded by the National Institute of Mental Health and the National Institute of General Medical Sciences, focuses on the relationship between sleep and mood in the perinatal population. Today, she will be sharing her insights on improving parent sleep in the perinatal period. Please join me in giving a warm thank you to Dr. Sharkey.
All right, Vesna. Well, you pulled through.
Drink of water.
Good work.
Hi, everyone. Thank you so much to Dr. Zinchuk and Dr. Buntak for inviting me. I really feel like Vesna was a true sponsor. I don't know, I've heard about mentoring from below, but sponsoring from below to invite me to speak, I really appreciate it. And I'm going to talk about something that I really am passionate about. So, and away we go. So you should be able to see this, and now you should be able to see it in presenter mode. Is that accurate? Fabulous. All right. So fun for the whole family, improving parent sleep in the perinatal period. So is the title of my talk. And here are my disclosure slide required by Yale, which inspired my color scheme because it came with all these fancy turquoises. Apologies to the colorblind. And this is the number that you have to text to get CME credit right here. So what I hope to do today is cover these objectives. So we're going to talk about circadian rhythms of sleep and how they change during pregnancy and the postpartum period. Talk about how we might recognize the difference between expected perinatal sleep changes and those that require intervention. I will tip my hand here and say there are no guidelines for how we decide that something is a problem. And so I have a couple of examples, but not, but that's not a codified, there's no practice parameter. We'll talk about some associations between maternal and infant sleep and circadian rhythm. So I started out being interested in moms and / birthing parents, but that interest has grown into how the intergenerational impact of this, of sleep in pregnancy and postpartum can affect both parties in that dyad, and then talk about an intervention that we're developing and just some of the other interventions that are out there. So the first, though, is why should we care about this? And these are slides from the Center for Disease Control that I got a few days ago. So yay, they're still up there. But unfortunately, they show pretty dismal maternal mortality rates in the United States compared to many other countries from around the globe. So the average number of deaths for American women is 22 per 100,000 live births. This is greatly amplified in Black women, where you can see that there are 49.5 maternal deaths per 100,000 live births, and how poorly we compare to other nations around the globe. So when we look at what happens with this, 2/3 of those pregnancy-related deaths occur during the postpartum period. So those are shown here, and most are within the first week to first month and 10 days. But then even after day 42, there are 30%. And I would contend that many of these are sleep related. So what causes maternal mortality in the United States? So by far the biggest is mental health issues like suicide and substance use disorders, including overdose. Then hemorrhage and cardiac issues come into play, infection, thromboembolic disease, cardiomyopathy, and hypertensive disorders of pregnancy. So, and I saw my colleague, Dr. Gada Borgili, who's an expert in sleep apnea in the perinatal period. And, I know that she has done incredible work in some of these areas, but we know sleep is playing a role probably in several of these items. How about infants? So infant mortality also is not great in the United States, where we have 5.6 deaths per 1,000 live births. And the top 5 causes are congenital disorders, preterm birth and low birth weight, which can be affected by poor sleep in mom, sudden infant death syndrome, unintentional injuries, which includes deaths by co-sleeping, and maternal pregnancy complications that affect the infant. Again, some of these are likely sleep related. And so here's just a figure from 2025 of data from 2022 about the increasing rates of suffocation and strangulation in bed, and this being noted more as a reason for sudden unexpected infant death, which is what SUID stands for. So that accidental suffocation and strangulation is rising. And again, we can talk about this, I hope, at the end, but this is a culturally bound practice. There are many cultures where the tradition and the family's decision is to co-sleep, but the rhetoric and instructions from different medical professionals is so anti co-sleeping that there are many new parents who don't talk about it with their physicians because they know that the messaging they're going to get is don't do this, which it doesn't go along with their preferences. And so it's, in my opinion, a missed opportunity to talk about how to do this safely, rather than, having somebody say, well, I'm just not going to tell my pediatrician that's happening. So that's those, this is the context that I want to talk about the work that I'm doing, because the bar for improvement is low in not having postpartum birthing parents die and in their infants not dying. So, all right, we'll now just review a little bit of data about how circadian rhythms and sleep change during pregnancy and the postpartum in both birthing and non-birthing parents. Here, anybody who's ever heard me talk has probably seen this slide before. I show it all the time because they're just beautiful actigraphic representations of, that sleep is rough if you are growing another person inside your body. So this is actigraphy. Each line going across is 24 hours. And each line going up and down is activity counts. And so this is going from midnight to midnight the next day. And you can see this is somebody third trimester, sleep's pretty disturbed. They're sleeping in on a weekend, or maybe they have Monday off because this is a Sunday into a Monday, but getting up a lot, lots of, it's not gorgeous. Now, and then here's postpartum week 6, which you have to, think is probably an improvement over postpartum weeks 1 through 5. And yet, postpartum week 7 isn't, it's not getting fantastically better on postpartum week 7, which again, sidebar, we also don't message very well about what are the right expectations to have parents have about what a new baby does. So I think that there's this idea that after 6 weeks, the baby is going to start sleeping and then something magic is going to happen. Maybe that coincides with the pitiful length of family leave that parents get after. So if, in the places where 6 weeks is what people have off, maybe those two things are somehow linked together. But we know that, that at 1 year, 43% of infants still don't sleep through the night, even even with no problems. Those are not parents that have issues or babies that are noted to be particularly difficult or have colic or anything. It's just that's development, and it's uneven when you're little and a baby. So it can take some time for sleep to consolidate. And anybody who is a parent on this call is, I'm not giving you stuff you don't know. I love this paper. So even though it's really old, I love to show it because this is Kathy Lee. And she just did this heroic job of recruiting people who weren't even pregnant yet, and then studying them at all these time points. And this was a study that used polysomnography. Heroic. And obviously the lines are drawn in, the lines that are in color, I added just so you can have a context of, people, we want people to be getting an average of, young, adults 7 hours of sleep. And you can see there's lots of people falling below this. There's no error bars in this data set. It's a small data set. The other thing to know is parents, there's a learning curve. So if you've done this before, those are the multiparous parents, mothers in black. You are pretty much looking better than the first timers starting in second trimester. So this is total sleep time. This is a really recent study that looked at over 750 participants, of whom just under 700 were female birthing parents. And it was a meta-analysis of actigraphic sleep duration. And this study found that the average decrease in total sleep time with actigraphy from pregnancy to the postpartum is 43 minutes, which is, as far as I'm concerned, a whole night of sleep a week, right? If you're getting through, that adds up to 300 across the week. We're talking about a lot of sleep. This is only the mothers or female birthing parents in this slide. They said, oh, there are these dads. They said the dads were average age 34.9 plus or minus 6. They did not report any data on the dads. Sort of annoying, but I have some dad data to show you in a few minutes. This is sleep efficiency. And again, in my mind, my cutoff is around 85. You can see it's not great. And here's sleep efficiency in that meta-analysis. Again, I don't know why they did the forest plots like this, where the positive effects were a reduction. This is the case for both of these forest plots, but the average decrease in sleep efficiency postpartum was 12.1%. And so, yes, this is sort of, you probably already know this. I'm going to show some data about circadian rhythms. So this is was data from my K23. So we measured melatonin onset at 3rd trimester and at 6 weeks postpartum. They wore the actigraph, lovely figure of the actigraph. We did the dim light melatonin onsets at home. We measured mood, and by the way, these were all women who'd had a history of a prior depression or bipolar disorder, but they were not in a mood episode at enrollment at 3rd trimester. So basically, in this sample, it was selected to enrich for people who were at risk of developing postpartum depression. So what happened, what is plotted here are all of the participants who we had 2 nights of DILMO, so we could calculate whether they shifted or not. And then we classified, so every bar is a person, and then advances are plotted here and delays are plotted here. A little bit over a third had no shift, about a quarter phase advanced over time, and then a little bit over a third phase delayed. So their DILMO was at a later clock time. So circadian phase is probably not staying stable in perinatal people. I think that, and neither is the phase angle. So let me just tell you what this is. So in this plot, every line is a person. The top dot is what the duration of time between their melatonin onset at pregnancy and their sleep onset time with actigraphy at pregnancy. So it's the phase angle between melatonin onset and average sleep onset time at 3rd trimester. And then this is phase angle between melatonin onset and sleep onset with actigraphy at 6 weeks postpartum. So this just shows what happened to the phase angle. Did it get longer or shorter? People, I think, have in mind that the average phase angle, so sort of I always think about a rule of thumb when I'm talking about how early the melatonin goes up relative to when somebody's typical bedtime is a couple of hours, but you can see there's quite a spread in these folks. And then the top versus the bottom is just, these are the people who their phase angle shortened from pregnancy to postpartum, and these are the people who it got longer, just to separate them out. Otherwise it would be like a game of pick up sticks in this on this slide with just lines going everywhere. So you can see that 2/3 of the folks got that phase angle got shorter. I think that, you know, my interpretation of this is that in a state of chronic insufficient sleep, which hopefully I and the meta-analyses have convinced you of, that what's really great and adaptive is if as soon as that sleep gate opens, you know, you want to narrow that phase angle. You don't want, melatonin goes up and you want to hit the hay. And in fact, the people in whom the phase angle lengthened had more depressive symptoms. But I'm not going to so much go there as I'm trying to kind of have like more of a, what are we doing with these families that are having children to try to help them as sleep people. But you can see that this relationship probably changed in my data set. And I hypothesize that that's adaptive. Light levels change. So, you know, why are people shifting and why might we see these changes in DILMO? So I know there's probably a lot of people on this call who don't know the old term called estimated date of confinement, but old people like me who did OB rotations in the 90s, oh, that's so long ago, know that the EDC used to be what we would call the due date. So, and lo and behold, it looks like it was true in these participants that they got less sleep after their estimated date of confinement. Were they really confined? I don't know. But so this is just light levels in the 2 hours after waking up. And you can see that was lower. And it was lower, that light in the 2 hours before sleep onset was also higher in pregnancy than in the postpartum times. And then this just shows the 24-hour day. Again, apologies to the colorblind. The blue is pregnancy. The pink, this is pink. It is 2 weeks postpartum. And then there's this kind of tan color and a green color. And mostly what I want you to see is that people are getting more light across the whole day when pregnant, and then the postpartum time points, and then really, especially at 2 weeks postpartum, more light at night. So when that's, potentially contributing to those phase shifts also. And then just because I can't resist, and this is a replication of, we know that night owls and people who are more phase delayed are more likely to have mood symptoms. And that played out in this sample also. So this was, what was their dim light melatonin onset clock time at 3rd trimester? And then did that predict their Hamilton depression score at about 4 months postpartum? And there was a significant correlation, but that's been shown in other non-perinatal samples. So, all right. So let's talk about non-birthing parents / dads. So new fathers, this always surprises people. So new fathers get less sleep than new mothers in the early postpartum weeks. And I wrote down the numbers because I was like, people don't love hearing this. So the one study that's cited here is Carol Gay, who worked with Kathy Lee at University of California, San Francisco. And in her study, the fathers got more minutes of sleep at night than mothers, but mothers got more daytime sleep. So the total sleep time for mothers was averaged 458 minutes versus 424 minutes in dads. And then another one that I have here is D'Amato. So this was a study of parents of twins, bless their hearts. And the difference between nighttime sleep and daytime sleep in birthing parents, mothers / fathers, was mothers got 6.2 hours of sleep at night versus 5.4 in the dads. And in terms of total sleep time, mothers got 6.9 hours versus 5.8 hours in the dads for when you added in naps. So anybody who knows me also is like, Katie's there Katie's there to support the women and the females and whatever, but dads are driving the cars and going to work and pretend, and making decisions and trying to keep the peace. And so we want to have everybody getting more sleep and feeling good. That's why it's fun for the whole family. So, oh gosh, someone's chatting, but I'm not even going to look at the chat, or if I start looking at the chat, I won't get through this. And then mothers talk about being more fatigued, but fathers talk about, or fathers actually have more objective daytime sleepiness when that's measured. And then it appears that, like moms, fathers, when they get worse sleep quality, are more likely to have depressive symptoms. So I really think this is something we do want to be paying attention to. And this is a cohort effect, right? So contemporary fathers spend more time caring for their children, and that tends to benefit. Oh, I didn't get my reference 46. I'll tell you guys what reference 46 is later during the questions. But this is a study that showed that the more involved the fathers were, the more paternal caregiving that was provided, predicted better mother and infant sleep consolidation. So it's important to have everybody involved here, and like, let's lift the boat for everyone in terms of getting enough sleep. Okay, so I tipped my hand earlier when I said recognize the difference between expected perinatal sleep changes and insufficient sleep. There's no guidelines, and so I think, again, as sleep medicine physicians, we want to think about, well, what do we already know, and how come we're not applying it and sort of raising awareness about it not being enough, if instead of the hand waving, yeah, well, you're pregnant, you're the one who wanted to have a baby, or the classic sleep when the baby sleeps, which anybody who knows things about circadian rhythms knows isn't going to happen, or when people are pregnant and expecting, getting told it's going to get worse, right? Like, not helpful. So here I just added back in the data. So here's Carol Lee's beautiful data. And then here are the data from that study that I showed you, the circadian rhythms data on, where I just have everybody plotted. So these violin plots are just all my people, so that you can see, wow, that's a lot of people getting less than 7. Wow, that's a lot of people getting less than 6. And this is chronic, right? I had both my kids during residency, and I thought, this is gonna be fine. Like, I take overnight call, but not every night. So there are definitely people who are just chronically getting what we would think is a dangerously low amount of sleep. And this is sleep efficiency. Oops, sleep efficiency. Again, I think of 85 as being kind of our normal cutoff, so no one's getting that. And this also reminds me to say that this is an area of missing, a real gap in the literature, I think, is that most of the work that's been done with objective sleep is with actigraphy. We really know barely anything about the intervals of sleep during a night of postpartum sleep, because the actigraphy data just gets swamped by the wakings to provide infant care, right? So at this point in our science, I can't tell you very much about someone who is a poor sleeper, even when they are asleep and not providing infant care, and someone who is a good sleeper. I don't know if they're all in all stage 1 that whole time that they're asleep or not. So hopefully that makes sense. And then we know that sleep disturbances during pregnancy are associated with lousy outcomes, longer labor, greater weight gain during pregnancy, and risk of not losing it, gestational diabetes, perinatal depression, premature delivery, right? So again, to me, as this is an opportunity as people in sleep medicine to say, whoa, that's not enough. That's like a lot of people not getting enough sleep. And then it's associated with all these things. And then we have this CDC data showing, wow, it's not great. We maybe need to amp our messaging to this population. And I just put this in because, this is something we talk a lot about when we talk about school start times. We talk about it a lot when we talk about medical trainees. This study the senior author was Louise O'Brien at University of Michigan. It's an anonymous survey of 72 parents with an infant under age 1. And 18% of them reported that they had sleepy driving at least once a week. And 8.3% reported falling asleep behind the wheel since their infant was born. So 20 of them reported that they had fallen asleep behind the wheel. Looks like they were more likely to be employed as shift workers. They did not have sleep apnea. It was more first timers than experienced parents. I think this is interesting too. The age of the child was a little bit older at the time of that accident. So again, does that speak to chronicity, and sort of how long do we let, this is 33 weeks, 2 weeks, 6 weeks, 16 weeks. like, how long do we let that go on before we're worried about the driving? They didn't differ in any of these measures down at the bottom: sleep duration, snoring, number of wakings, typical driving distance. Okay, so I want to talk a little bit about, kind of go back to those previous slides and just talk a little bit about the dyad. So we took a bunch of subjects that were in one of several studies, and just asked them if we could measure their baby's sleep. So this was you agreed to be contacted on your IRB form about future studies. And then one summer, my research assistants, Julie Quattrucci and Sarah Carr, worked with a student named Bailey Driscoll, whose picture I'll show you, I think, in the next slide. And we just said, hey, it would be cool to look at like mom's sleep during pregnancy, and then what was going on with their kiddos. And this was really a sample of convenience. It's super exploratory and hypothesis generating, but it's not, we had access to them, and we wanted to try it. So, and you can see like this mom and this baby look kind of different than this mom and this baby. Interestingly, the delay, this person was more delayed, and look how much more delayed baby's bedtime was, a 3-year-old. And this is 3 years later, right? So that's the other thing I'll say in defense of these data is we have no business finding anything in this data set, honestly, right? Because it was, this sample of convenience, and then, just asking people 3 years late, up to 3 years later, what was going on. So, but let me show you what we found, if this will advance. Okay. So who were they? It was 31 mother-child dyads. The mothers were, behaving, 31 years old. The children were on average 2.3 years old. We had just randomly nicely balanced sex, and a pretty diverse sample. That's Bailey, and this is my colleague, Dr. Taylor Von Ash, who studies infant sleep. And we looked at mom's actigraphy during pregnancy and during week 2 postpartum and week 6 postpartum. And then those are the independent variables, is looking at what was mom's sleep like during these times. And then the dependent variables were the child and whether they had sleep, the parent reported sleep problems on the child's sleep habits questionnaire, or whether we found issues with sleep in the child's actigraphy. I'm going to show you slides that are really a 30,000 foot view. So it doesn't matter what any of these numbers are. The 3rd trimester maternal sleep did not predict child sleep problems, either by actigraphy or by parental report. The 2-week postpartum maternal sleep predicted, out at age 2.5, quite a number of issues with the child. And then really nothing too exciting at 6 weeks. So again, I don't want to make more of these data than they are. Hopefully I talked them down enough that, I don't want to say, well, we've solved it. But the fact that we get a signal here, I think, is super interesting. And the fact that it's very early in the postpartum period, 2 weeks, is pretty early. I don't know how many parents are on this call, but like all bets are off at 2 weeks postpartum, right? Like you are like, can we live through this? Did anyone get to shower this week, right? I mean, it's really early times. And so I'm really interested in what, I think this is picking up maybe a physiologic dynamic, but certainly a environmental dynamic, right? About like, who's there to help, who's like, how and by the way, they're all these associations are in the direction that you would expect them to be, right? Like if it was worse, it was worse, right? So is it sort of then telling you something about the environment, that we're measuring mom, and then later, is that what's showing up? And then by 6 weeks, maybe the ones who are going to have good temperaments had them, or maybe everybody got it figured out. I don't know, but I think this is provocative and it interests me. And y'all are smart people, so maybe you'll have some ideas about how I'm open to other ideas about this. Okay, so, and then I want to spend a couple minutes talking about interventions. And I'm going to show you a cool video, and then hopefully, I definitely want to have time to talk because I am interested in what people think. So interventions to improve maternal sleep. Historically, these have mostly been aimed at preventing infant sleep problems, which is I think is interesting because infants are going to infant pretty much, right? Like they're uneven and they have to develop. And as I said a few minutes ago, 43% of them are still not sleeping through the night at 12 months of age. So what is going on? People have tried lots of things, information about infant sleep, strategies that will teach infants to self-soothe, whether you call that ferberizing or something more gentle, practices that facilitate day and night entrainment. And very often the parents are like an afterthought, which again, that just blows my mind because they're the ones driving these babies in the car and trying to interact, and trying to have bond with them and trying to stay married to each other if they're married, or stay together if they're not married, so that they potentially have the advantages of being in a two-parent family. And we don't even know. There's an exception, which is a reference on the wrong slide, Sharkey. So this is again my hero, Kathy Lee from UCSF. So this was a study of 2 samples of expectant parents, and one was a very socioeconomically advantaged, Palo Alto group with 2 parents and good income and high education, and then one was a more challenged group from a socioeconomic perspective. I think that the qualification was they had to be able to be eligible for WIC, and they delivered this intervention prior to the delivery, which I think is critical, that you can't wait until the postpartum and then hand people like an infographic about how it's going to go. And it was really very low tech behavioral things. They taught people you need a nightlight. They like, do not, don't turn all the lights on at home. They had everybody have a sound machine, and they had all of the babies rooming in with the parent or parents, and which is the recommendation, by the way, of the American Academy of Pediatrics, that that co-rooming is the party line right now. So there was no effect in the socioeconomically advantaged sample in sleep, but in the low income sample, where there was more sleep disruption at baseline, they got more sleep. They had higher sleep efficiency. They had less time after sleep onset. So, and again, my bias is that they were trying to help 2 groups, and one of the groups needed help and one group didn't need help, and that we would do well to focus our efforts on the people who are really for who we can make a difference in. All right. So this led to this cool project that we're working on now, which I call the Dream Team, which I know is not that original to this group, but everybody else thinks it's cool. This started because I'm friends with this lady here, Jane Hesser. Jane is a fine artist. She used to be a professor at RISD, And then she got a master's in counseling, where she focuses on perinatal people. She worked at the Women and Infants Hospital for 10 years and did something like 3,000 intakes into their day hospital program. So, and Jane and I just met because we're both in the community, and she was like, sleep, it's all about sleep, I think. And we befriended each other. And then there came, so we started giving talks for Postpartum Support International, which is a very grassroots and hands-on. So this is not like faculty at Yale and Tufts and Brown and Harvard, et cetera. This is people in community settings, sometimes where they're the only one that'll take care of a pregnant or postpartum person. And they were really hungry to have these lectures about sleep. And so we did a few of those. And then we got a call from this lady. This is Katie Taylor. She works at the Palo Alto VA and is one of the developers of CBTI Coach for the Department of Defense. And she was like, hey, can you guys help me write some perinatal sleep content for CBTI Coach? And we said, sure. And then there were these couple different RFAs. We didn't get funded the first time, but got funded the second time to get help from these two folks, Ari Albanese and Dr. Hannah Frank and Dr. Ari Albanese, who are implementation scientists in the Department of Psychiatry and Human Behavior here at Brown. This is my biostats pal, Dr. Janine Molino, and this is Carlos Toro, who is a filmmaker in Rhode Island. And we wrote a grant to say, hey, what if we start getting people who are the Postpartum Support International customers and stakeholders, and try to find out what do they want to know about sleep, and then kind of try to make an educational platform for these folks to deploy to their clients, because they do these home visits. So that got added to CBTI Coach. How cute is that? So cute, right? And we have all these different topics. And then we started working with this group to, how do we decide sort of what was going to be here and what was going to be in these videos? We asked the people who came to Jane and my talks for Postpartum Support International, like, what do you already know about? And so they know all about advocacy and impact of sleep. That, like, they're like, fine, we got this. They want to know about naps. What should they get? What advice should they give? They especially want to know about naps if the person has more than one kid. They don't know much about circadian rhythm, so lots of them wanted to hear about that. They didn't even know there were apps that that were available for sleep. And so you can see, I'm not going to read all of these, right? But you get the idea that there were gaps. And so that led to, okay, stop share. So we did 5 focus groups, and those data are still being analyzed, but then we also made these groovy videos about the sleep topics that I showed you in the app. So let me share this and share sound and optimize video. Oh, I have to pick a video for it to want to do video. All right, this worked in rehearsal. Can you see a purple thing? Now tell me if you can hear. Yeah.
People think a lot about how sleep will change after the baby arrives, but pregnancy itself impacts sleep too. When you first become pregnant, hormonal changes, especially those rising progesterone levels, can make you feel sleepy during the day. And by the 3rd trimester, most pregnant women report some trouble sleeping at night. There are a number of common things that can make it harder to sleep in pregnancy, like more trips to the bathroom, trouble finding a comfortable sleeping position, aches and pains, and too many thoughts running through your mind, and feeling too hot or too cold. And there's more. It is really important to build healthy sleep habits during pregnancy. Poor sleep during pregnancy has been linked to blood pressure problems, including an increased risk for preeclampsia, low birth weight, higher rates of C-section, longer time spent in labor, and postpartum depression. Paying attention to your sleep habits during pregnancy can lead to better sleep after the baby arrives. Plus, healthy sleep may protect both you and the baby from certain health problems. Here are some strategies that have been shown to improve sleep during pregnancy. Set regular bedtime and wake-up times. Even if you don't follow these times to the minute, following a routine helps your body clock stay regular. Plan ahead so you have enough time to get the amount of sleep you need. Aim for at least 7 hours per night, but don't worry if you get less than that on some nights. It happens to everyone. Also, try not to make up for lost sleep by sleeping in or spending a whole day in bed to catch up. This can throw off your internal body clock and make it harder to fall asleep and or wake up the morning after the next few days. If aches and pains disturb your sleep, even discomfort that is expected during pregnancy, consult your doctor or midwife. Being pregnant doesn't mean that you can't be treated. There are physical therapy techniques and safe medications that may help. New bodily sensations can disturb sleep because of the actual physical feelings and worries about whether these sensations mean there is something harmful happening to you or the baby. And when these new feelings and worries happen in the middle of the night, it can be harder to put them out of your mind. If you have new symptoms that keep you from sleeping, talk with your medical team for guidance about whether the discomfort is normal or needs further evaluation. Set aside time to wind down at the end of the day. This help keeps the worries out of bed and get your body ready for sleep.
So that talent, which is what the film guy calls them, our actors, the talent, I love that, is a certified lactation consultant and a former home visitor, community health worker. So, all right, I'm going to go back to my slides for 1 minute, and that was one of the shorter ones that we have, but I hope you'll see that that had sleep information that everyone on this call knows, but also a lot of information about advocating for oneself, right? Around what might or might not be normal during sleep. Okay. So let me go back to my slides. There we go. All right. So that's my last slide. But I think that then maybe we can talk for a minute about, so sort of what are my asks? I mean, and what do I think we should be doing? We're still this grant is ongoing. You are the first people outside of the Dream Team people to have seen that video. So I hope you feel like world premiere, woohoo, is very exciting. We're things that I think about are, we have to start knowing what's going on with the fathers when there are two-parent families. We also have a section in the education about what if you are a single parent, how do what do you do and how do you make this work? I think we have to realize that sleep literacy is not high, right? And in the age group of people who are having children, often they're like, well, they're young, they don't have, it's like they don't have to eat the broccoli if they don't want to, and they don't have to have a sleep schedule maybe if they don't want to. But nobody's sort of gone back to this young adult group and said, hey, this might be important. So I think I'll stop there. I guess one more thought is, who is this for? Is it for people who have a problem? Is it for everyone? And I don't know that I have an answer for that yet, right? Because to me, there are people that are at high risk, right? But if we did a better job with sleep literacy in the population of young families, we might be able to skim X% off the top that just wouldn't then have a sleep problem, if we could give them a little bit better education in sleep literacy. So that's it for me. Let's hear what you think.
Great. Thank you. Thank you so much. Appreciate it. That was a enlightening talk for me. And I won't touch the hot potato of dad's data. Oh, sorry. I think. Sure. That's it. I'm not sure if I can hear. I think you're muted, Katie. Let me see. Unmute. Oh, that's fine. Well, while we do that, give me 1 second.
Great, now I'm unmuted, sorry.
Okay, great.
No, I don't think that's a hot potato. I mean, all parents are important to the process, right? And
Sure.
I mean, there's just the fall asleep in the car data. Eek.
Right,
That's
right.
terrible.
All right. Well, so I think there's a question from Dr. Yagi. And so Dr. Yagi is asking, it seems like most of the common questionnaires that we use in sleep, like ISI, ESS, PSCI, were not designed to measure the unique barriers to sleep imposed by the perinatal period. And are you aware of any sort of promise type measures that have been validated in this population?
That's a great question. I am not. The
Maybe you can tell us what promise is, just so for the audience, in case folks are not familiar.
so the promise questions are, oh gosh, I have to Google it.
That's okay.
They are a cluster of I think questions that were, maybe Clark should tell you, that were
I'm sorry, Katie.
They're consensus built questions, and I think they get a little bit more at like patient-centered features. Clark, am I right? You can save me.
Yeah.
Save me, Clark.
I'm
Yeah.
muted. Oh, I'm not unmuted. Yes, it's patient-reported outcome measures in science. I think it's like an NIH effort. There's a whole process, and I think it would align very nicely, honestly, Katie, with your work. Sort of a protocol to go through to generate a validated questionnaire for a specific population. And given given all of the barriers that you listed in that one slide that sort of informed that intervention you did in CPDI cards, it's low-hanging fruit to develop something for this population that could be measured. Because I mean, most of your work, it seems like, used an objective measure, i.e. actigraphy, but gosh, it would be very helpful clinically to have a well-designed questionnaire to reflect the burden of sleep deficiency in this population.
Yeah, I agree. That's a great question. If anybody else on this call knows whether the promise items have been validated in perinatal people, please feel free to ask Andre to unmute you or write it in the chat. I'm not aware of that, but and actigraphy is not going to be the answer, right? We're going to have a measure that can be used clinically to see to make impact on the scale that I think we could make impact on, I guess. So, and most of my work has been in people who have a psychiatric diagnosis, right? Or have a high risk of developing postpartum depression. On the other hand, many of the things that predict somebody getting a perinatal mood disorder are things that we don't have control over, like as sleep medicine physicians, right? I mean, I'm not going to change people's socioeconomic status broadly, but this is pretty, I think it's probably safe, right? Like this, there's low side effects, right? And as we started, we've learned a ton in the Dream Team study, which is a supplement grant from Mary Carskadden's, it's a women's health supplement on her Cobri. And we really thought that the videos were going to live in that CBTI coach app, but then we realized that's super confusing because it's not CBTI at all, right? This and what many of the videos have now, they're sleep related, but they also all have this element of, you got to speak up that if you need help, you've got to be able to like know that something's not right, or that it's not normal to feel this way. So yeah.
Yeah.
All right. So I
I
see.
mean, that's fascinating. Yeah. Let's see. So there's a question from Richard Jang. It says, for two-parent households with newborns, do you discuss how to schedule nighttime wakings amongst the two parents, alternating or doing a night shift?
Yeah, that I love that question, because so in
Very
another,
pragmatic.
yeah, and we did I have a study. The first author is oh, I might be the first author, or it might be Gordon. No, I think the first author is Gordon, Gordon, first name Lily. That was a kind of mixed methods looking at breastfeeding. And so we interviewed people before, at third trimester, and then at 2, 6, 16 weeks postpartum. We asked them what their breastfeeding intentions were, and also what their sleep strategies were. And that study showed that people who had better sleep during pregnancy were more likely to initiate and continue breastfeeding, but the qualitative data also showed that some families did discuss it, and that was the divide and conquer method that I think is being suggested here was the one that was a very common theme. Like when people said they did, many people said, we have no plan. We think it's going to suck. We're very worried. Like, and these were just the interviews with the birthing parent, not the mom, who I say birthing parent because I think we're going in a more gender neutral direction, but to be truthful, these people all identified as moms in that sample. But your point is, yes, absolutely right. And sort of trying to figure out, and maybe that plan ahead piece that we have our actor saying, speaking about, maybe even should say, and coordinate with the other grownups in your home. I know there is another video that says exactly that. Like, you do not have to get up and do every single baby thing in the middle of the night. If there is another adult, there's no reason for everybody to be awake for every single thing. Any training on the, do you want to ask this?
Oh, go for it. Absolutely.
Dr. DeAngel said, any training on the OB-GYN side to integrate sleep questions into the prenatal visits? I think that the OB-GYN factor is so interesting, because I think that OB-GYNs must have a ton of cognitive dissonance. Again, they're like, well, we're up all night, delivering babies. I think, it's sort of a joke, but I sort of also think it's true, right? That they're not the most sympathetic people to complain to about, gee, I'm up all night and I'm not getting enough sleep. But I think, yeah, there's a ton that we could do there. I'm also worried about the time. Is this a conference that goes over? Or
you're welcome to go over. People will jump off as they would like. We have another conference at 3, but we can, it's a plus minus wiggle room.
I just don't want to
go for it.
The data on mom and baby sleep is interesting. This is from Gata. Do you think the association is unidirectional? I'm thinking biology during pregnancy. I don't know. I think it's really hypothesis generating, Gata, right? Like that, but that 2-week, and again, the reason I showed those terrible tables that were just numbers that weren't great slides was just to show you, look at all the associations at that 2-week time point that weren't present at the other time points. I think that's a signal that makes me want to look further and try to understand what's happening there. But it's because I think it could be biological, right? That's just like, that is before you've put anything into place. It's when people have a 2-week-old, 1-week-old, this is actually week 2. So we drop that actigraph off like 7 days after this baby comes. It's very early, right? And they don't have their acts together yet. So Oh, and Gata also gave us, Dr. Borgili says, there are validation data on Pisky, but not at birth and not aware of promise. Should I keep going? You guys have to cut me off. I'll expand to fill the space I'm given.
So maybe one more question and then we'll end the discussion.
Okay. So Dr. DeAngel just made a comment that says, at the 2016 and 2019 Yale New Haven Hospital
Health, yep.
Okay. New parent orientation, they suggested fathers should always wake up with breastfeeding mothers to support them rather than divide and conquer. I almost died. Yes, that's bad. That's what I'm saying, is that as sleep medicine docs, I think this is a great place to end. And Dr.
Yep.
I'll answer yours is sort of the same question, right? Is like, this is a call to action, everyone. Like, sleep, this is stuff we know, and it's clearly not getting transmitted and translated to, if at Yale New Haven they're saying both parents need to be up in the middle of the night for breastfeeding, like, that is not great advice. I don't think, right? I don't want to drive on 95 when they're on that road, Lordy. So I think sort of doing a better job of translating, of all sleep providers, translating the things that we know and that are intervenable and implementable into people who are growing their families is critical. And again, I'll be honest, I know this will be the last thing I say, is just I think we need to target people that we know are vulnerable, but I also think this is not that some of these interventions, like, hey, have a sound machine, hey, put the baby in the room, hey, don't turn all the lights on because your circadian rhythms are going to shift, like that. There are no side effects for that. Like, you know what I mean?
Right.
Like, it's not.
Yeah. And the beauty is that, these are not terribly complicated interventions, and people most vulnerable and at risk tend to benefit the most. So to me, it seems like a no-brainer for an intervention policy, and incorporating actually sleep into the public health component of what we do, which is more or less absent in general. Public health focuses on infectious diseases, preventing maybe heart disease, well, maybe cancer, but but sleep is not really part of that conversation. So I think that's a great opportunity to incorporate it. Well, listen, so great to have you here. Wonderful talk. I have written down some questions, but maybe I'll email you if I afterwards. Have a great day, everybody. And looking forward to seeing you all in 1 month's time in March.
It was great to see everyone.
All
And
right.
thank you so much for having me. And thank you to Dr. Buntak for bringing Brown into the fold.
All right. Excellent. All right. Bye, guys.